There are no financial disclosures in the subject matter of this video. Intraoperative floppy iris syndrome is a major intraoperative challenge for any cataract surgeon. It can lead to iris billowing, progressive constriction of pupil, iris prolapse, excessive fluid usage, posterior capsule rupture and nucleus drop. These problems give a lot of stress to the surgeon as well as patients and may result in suboptimal outcomes. IFIs is encountered in a good number of patients, and the incidence of floppy iris or iris prolapse is high in patients on alpha-1 antagonists. Iris touch and unstable anterior chamber play a very important role in these patients. Let's understand pupil dynamics to iris touch in a normal patient. An iris touch stimulates sphincter muscle contraction, which is opposed by the strong dilator tone of the dilator muscle. There is minimal pupillary constriction. However, repeated trauma causes pupillary constriction. In patients using tamsulosin and similar drugs, the compromised pupillary dilatation and the iris billowing predispose iris touch, which precipitates pupillary constriction because of weak tone of dilator muscle. We did a thorough literature search to find the missing link. The improper calibration of side port incision is one of the major precipitating causes. There was a flux of fluid to the side port incision with iris touching the side port instrument, thereby precipitating IFIs. Can we prevent IFIs with the available knowledge? Can we minimize IFIs? Yes, we can. Calibrated side port apparatus is the answer, with calibrating side port incision and instrument according to size and shape. However, there were a few challenges. There had never been calibration of side port incision, unlike calibration of primary incision. There was a disparity in the shaping between elliptical incision and cylindrical chopper. There was a wound mismatch. Studies showed that side port incisions were predisposed to leakage, and the side port leakage decreased with the size. We studied the different side port incisions and further divided the side port incisions into 4 types in our study. Type 1. There is calibration of side port incision and chopper, no iris touching, no pupillary size change, no nuclear piece in subincisional area, and little efflux of BSS through side port. Type 1 incision exemplifies excellent effect of calibration of side port incision. Type 2. Mild non-calibration. There is iris billowing and intermittent touch, pupillary constriction, occasional nuclear pieces in subincisional area, a flux of BSS through side port. Type 2 incision symbolizes mild non-calibration with traumatic meiosis. Type 3. Moderate non-calibration, intermittent iris touch, pupillary constriction with peaking. There are nuclear pieces in subincisional area, and there is a large efflux of fluid to the side port. The increased mismatch in calibration causes faster pupillary constriction with peaking of the iris. The nuclear pieces get lodged subincisionally too. Type 4. There is severe disparity in calibration. There is continuous iris touch with subsequent iris prolapse. Nuclear pieces are there in the subincisional area, and there is large efflux of fluid to the side port incision. There is a gross mismatch with continuous iris trauma and meiosis. The aim was type 1 side port incision. We were already calibrating the sizing of our incision. We opted for syncing the shape by having round incision for round instruments. We chose a 25 gauge needle which had outer diameter of 500 microns. The shaft of chopper was correspondingly cylindrical. We wanted to calibrate the sizing too. The side port chopper has a cylindrical shaft which matches with the side port in shape. The diameter of the shaft has 450 microns at the distal end and 500 microns at the proximal end. The variably calibrated sizing helps maneuver the side port instrument during nuclear emulsification. Our side port calibration provided round incision for round instruments. Additionally, the bevel cutting edge of the needle helped create a tunnel. There is no sideways cutting or enlargement, making the side port incision precise. The needle provided unique tunneling advantage in corneal stroma, which further helped in sealing. There was easy intraoperative sealing. Occasionally, the side port was self-sealing. How would side port incision help in preventing IFIs progression? Let's understand the progression of IFIs syndrome. Iris touching caused by iris billowing precipitates progressive pupillary constriction and ultimate iris prolapse. Calibrated side port apparatus minimizes iris touch to subthreshold levels, thereby halting IFIs progression. In the study of 105 patients on tamsulosin, there was no IFIs in 38 patients. There was mild IFIs in 67 patients. There was no patient with moderate or severe IFIs. The other advantages of side port calibration include unmatched chamber stability, excellent fluidics, minimal pigment dispersion. There is sustained pupillary dilatation with minimal decrease in pupillary diameter. The procedure is less painful because of decreased iris touch. Summing up, side port calibration will open up new frontiers for IFIs management.
How many cases you have tried this?
Yes, sir.
How many cases you have tried this?
Sir, we have been doing it we are regularly doing it in all the cases. But this study, we have shown 105 patients on alpha-1 agonists.
There is a slight difference between a video presentation and a video paper.
Yes, sir.
This qualifies as the latter.
Okay, sir.
Thanks.
Thank you, sir.
Just one final question. You have said these 4 types of side ports.
Yes, sir.
Have you got any sort of a correlation that the pupillary reconstruction was so much when this was this type? I mean, I understand your logic.
We did it in our own study. We divided it into, it's not from the literature.
Right.
Yeah.
But then have you got it demonstrated that if it is like this type, then the pupillary reconstruction was so much in so many cases? Have you got a record of that?
According to the different size of the side port, we divided the types.
Agreed. But then you say the pupillary reconstruction is more if there is a type 4, right?
Yeah, exactly, because it's a type.
I agree,
yeah,
but
yeah.
then have you got it documented as to in so many cases it happened with this type, this correlates to this, that?
Yeah, so we don't, we are not using the type 4 side port from last few years, but we just did it from the online videos, and we saw how the side ports are making people. So
there is no comparative.
yeah.
Thank you.